Hey guys, my name's Kristen. I am going to talk about hiatal hernia for my topic, and it's actually a case that I had this past weekend with one of my patients. It's a 59-year-old female. The only past medical history that she had is GERD and COPD. Otherwise, she had no other significant past medical history and no past surgical history. She actually started having some nausea and was complaining of her food coming back up, regurgitation, with acid reflux. She did complain of difficulty swallowing at times. She did try some acid reflux medication, but was unsuccessful in treating her symptoms. As the weeks went on, her symptoms got worse, and so they decided to do an endoscopy where they found inflammation and hiatal hernia. If you don't know what endoscopy is, basically a tube. It's like thin, flexible, with a light and the camera on the end, so they can look at your esophagus, look at your stomach. Patho, basically, hiatal hernia occurs when the upper part of your stomach is bulging through your diaphragm. Your diaphragm has a small opening, the hiatus, which is where hiatal hernia comes from. The hiatus is where the food tube, your esophagus, passes through before connecting to your stomach. So in the hiatal hernia, the stomach pushes up through that opening and into your chest, which is where you get your regurgitation of the food and everything. Usually hiatal hernias don't cause any problems, and you may not have to have any surgical intervention, but a large hiatal hernia can cause food and acid to back up into your esophagus, which can cause heartburn, which is what is happening here with this patient. Some classic signs and symptoms are heartburn, regurgitation of food, backflow of acid or acid reflux, difficulty swallowing. You can sometimes have chest pain or abdominal pain, shortness of breath, and sometimes vomiting of blood or passing of black stools, which may indicate a GI bleed. And she had a few of these classic symptoms. She wasn't having any signs of bleeding or anything. As far as the shortness of breath, she already has COPD, which can complicate that. So that's something that we want to monitor, especially with surgical interventions. They're not really sure what causes hiatal hernias, but they say that it can be caused or related to age-related changes in your diaphragm, injury or trauma to the area with certain types of surgeries. If you're born with an unusually large hiatus, or persistent or intense pressure around the muscles, such as coughing, vomiting, straining during bowel movements, exercise, heavy lifting, and things like that. Risk factors for hiatal hernias can include being older, like age 50 or above, and obesity. This lady wasn't really obese, but her age may have played a role in that. So treatment, if can't be managed by non-surgical interventions or surgical interventions, and this particular patient underwent a toupee fundoplication hiatal hernia repair. So basically, they can either do the toupee fundoplication or the Nissan fundoplication, and they take the fundus of your stomach, like the top of your stomach, and they wrap it around your esophagus and suture it tight. In the Nissan fundification, they do a full 360-degree wrap. So they take the fundus and they wrap it around your esophagus, pulling it down and anchoring it there so that food and acids and things can't regurgitate back up. But with hers, she had a toupee fundification, which is a 270-degree wrap. And so they take that and just wrap it, the fundus of the stomach, 270 degrees around. Sometimes patients do have to go back and have the complete wrap done. Some have peg tubes placed during surgery. She did not have one. And honestly, I'm not exactly sure what the requirements are for that, what causes them to place the peg versus what doesn't cause them to place the peg. But however, after these surgeries, all patients do have to have their medications crushed for at least the first 2 weeks or longer. They generally start them on a clear liquid diet after surgery until they're passing gas, and they gradually, and they make sure they have bowel sounds. They start them on, they graduate them to a full liquid diet for 2 weeks and slowly start introducing solid foods. Usually they start with softer foods like pastas and things like that after about 4 weeks. Usually these patients have to have no gum, no straws, no carbonated beverages, and that's like a lifetime thing. Their headed bed has to be 30 degrees or greater to prevent aspiration and regurgitation. They continue that at home. We've started giving them a medication called Interreg, which is a gut motility stimulator. It helps keep the bowel functioning and moving after surgery, and allows pain medication to work without slowing the gut. And as far as I know, as far as outcomes go, this lady did really well post-surgical. A lot of patients have difficulty after surgery as far as pain goes and deep breathing. They have trouble because usually, if they have to have an open surgery, then it's difficult for them to take those big deep breaths in. So complications can include pneumonia, especially from not breathing. They hate doing their incentive spirometer. Another big complication that we look for is an ileus of the bowel. So we try to listen to their bowel sounds frequently and encourage them to get up and move. We try on the first day after post-op day, but it doesn't always work. They're not always cooperative, but we really try to encourage that as much as possible, and that really helps to encourage gut motility. And we like to see these patients passing gas, and we like to hear those bowel sounds. So another complication is bleeding at the surgery site. We pay close attention to that. Infection, especially in the hospital. And sometimes if the patient has the wrap, the actual surgery, where I talked about them taking the fundus of the stomach and wrapping around the esophagus, sometimes that wrap can be too tight on the esophagus and the patient has difficulty swallowing. You'll hear them a lot talk about the food gets stuck. They feel like something's stuck when they're swallowing. And that doesn't happen often, but that does happen. So sometimes they have to get a second surgery for that. Otherwise, this lady, she didn't have an open surgery. She had a laparoscopic surgery. She had 5 lap sites. They do the dermabond. She did really well. She was a trooper. She was at walk-in first post-op day. She's passing gas. She went home after day 3. They were watching her oxygen and everything because of her COPD. It took her a little bit to get that back, but she did great. Her outcome was great, and hopefully that continues for her. So I don't know if anyone has any questions they want to ask, but thanks for listening.